Ontario's vaccine rollout may have gotten off to a slow and rocky start, but despite ongoing issues with booking vaccine appointments, more than 12 million doses have now been administered province-wide, and increasingly that includes people with 2 doses. With us now on what it all means, especially for the summer ahead in Mississauga, Ontario, Dr. Zain Chagla, Associate Professor in the Department of Medicine at McMaster University and an infectious disease specialist at St. Joseph Healthcare, Hamilton. And in the provincial capital, Ashleigh Tuite, infectious disease epidemiologist at U of T's Dalla Lana School of Public Health. And Maria Sundaram, infectious disease epidemiologist at ICES, formerly known as the Institute for Clinical Evaluative Sciences. Hi, welcome to you all.
Thank you.
Hi. This has been, there's a lot of hope out there right now. The summer is upon us, the weather is great, people are getting double vaccinated. And Dr. Chagla, I wanted to start with you, just because you're in my former town of Mississauga, Ontario. No, that's how it's been set up. But Dr. Chagla, the Delta variant has slowed the reopening plans for the UK. They were actually supposed to reopen this weekend, and now they've extended, they're now going to be reopening until, I believe, July 19th. And Theresa Tam has warned us to be cautious when it comes to the reopening plans that we have, not just for Ontario, but for the whole of the country. I don't seem to be getting that sense of urgency. As I mentioned, summertime, people are on the patios, the weather is nice. How worried should we be about the Delta variant?
Yeah, I mean, I think obviously this throws another wrench into everything in terms of us, knowing what COVID-19 is going to look like long term and the evolution of how this spreads. But, this is a very different position than when the Alpha variant of B.1.1.7 was circulating. We have vaccines, numbers are much better. I think there is a lot more hope in that context. Certainly, I think we do need to mass vaccinate our population aggressively. And there's been an incredible amount of effort going into getting second doses into individuals, knowing that the efficacy is much higher for a second dose as compared to a first dose. There is certainly a need to be careful with reopening and monitoring particularly hotspots for Delta variant and making sure vaccinations and testing are appropriate there. But again, the UK gives us a window. Recall they're relatively open still. What was going to happen next week was, their so-called Freedom Day, where things go back to 2019 levels. They've been able to show us that the Delta variant on the back of a partially vaccinated population, on the back of more controls coming out of society, that there may be transmission, and that may translate into hospitalizations and healthcare utilization. For us, as we're starting to escalate back into that, it gives us pause, making to be ready to get to each level and monitoring each level going forward. And I think the last bit that's missed in all of this is that there is a disproportionate amount of the Delta variant that is affecting those that are not vaccinated. And some populations, we obviously can't vaccinate in children under the age of 12, but even in those populations that are not vaccinated, they are seeing the largest burden of the Delta variant. And it is going to happen here in Canada and Ontario. And part of our strategy in the next 2 months is really reaching those hard to reach populations, as they're going to be the ones represented in healthcare.
Maria, Dr. Chagla mentioned children. We are going to be talking about them in a few moments, but he also mentioned hotspots. So this past Monday, the vaccine eligibility was moved up for people who had the AstraZeneca vaccine. And there seemed to be a lot of activism on the ground, a lot of doctors speaking up about the need for, as Dr. Chagla said, for people to get 2 doses. I was lucky enough to log on by 8 o'clock, and some people weren't so lucky. My husband logged on maybe an hour later, and we live in Scarborough, which is a hotspot, but the suggestion was for him to travel to Orillia. And I also saw on social media, Mississauga, there wasn't any place in Mississauga where people could go within that city to get the vaccines. So obviously there are some problems still with booking vaccines. Should people just take the first appointment they can get no matter where it is, if it's in a hotspot or not?
This is a really great question. Unfortunately, the answer is a little longer, but I'll try to be concise. So Overall, the answer is yes. If you can get a second dose, you should get a second dose. You may have seen that NACI just released guidance yesterday suggesting that for those who got the first dose as an AstraZeneca vaccine, they ideally would get an mRNA vaccine for their second dose. That might not be possible or accessible to everyone. It's really challenging, though, to tell people, hey, we prefer that you get an mRNA vaccine, because then it feels like if the second dose has to be AstraZeneca, they feel like they're not getting the best possible result, and that's also a problem. You kind of alluded to this issue of accessibility in hotspots, and I think that really comes back to vaccine equity conversations that we were having for the first dose, even back to February. We're seeing now, based on data from ICES, that unfortunately we're seeing the same equity problems with dose 2 as we saw for dose 1. This is not perhaps terribly surprising because, first of all, the people who are eligible for dose 2 already got their dose 1 a while ago. Those were the people who kind of had access in the beginning. But we still have these rollout logistical challenges with getting vaccine to the neighborhoods that really need it the most. So I think in many ways, we're just kind of like, with each new page that we turn in this pandemic, there's a new challenge, but it's a challenge that's also hopefully not unfamiliar to us. And we really need to start taking those challenges, especially the ones with vaccine equity, very seriously.
Like Dr. Chagla said, we can look to the UK to learn some of these lessons, and we know what the rollout for the first dose was like. So you would think that maybe for this second dose, things would be changing. Again, I want to ask you, maybe I want to reframe my question, because we've had this message from the government and from health officials saying, don't travel to other regions, when we did have the stay-at-home order. And now we're being offered vaccines that are, you might be in a hotspot, but then you're getting a vaccine, but that's not in a hotspot. So should you still really be doing that? Should we be doing that?
That's a tough question to answer. I would say my guidance and advice for individual people is, if you can get a second dose, you should. I totally agree with Dr. Chagla's, thought that, we really need to get second doses into people, especially with exploding variants of concern. We know that the vaccine effectiveness post-second dose, especially for those variants, is much better than for just the first dose alone. And I really hope that also helps people feel a little bit more comfortable as things do start to open up sort of simultaneously. But it's really challenging to issue guidance saying, hey, we prefer that you get an mRNA vaccine as your second dose if you got AstraZeneca as your first dose, and then not make that option available to people. So that also really does need to happen.
Ashleigh, I wanted to follow up with you. Maria mentioned that NACI changed the guidance and said that if you did get an AstraZeneca vaccine, that it's preferred to get the second mRNA. Why did they change their position?
So I think they changed it based on a couple of things. The main one is supply. At this point, we have enough of the mRNA vaccines that we can offer mRNA vaccines to anybody who wants it. And we have data, not all of the data that we would necessarily want in terms of, we don't have population studies where we've gone out and done this and sort of looked at the effectiveness of a mixed dose regimen versus 2 AstraZeneca doses. But we have some studies looking at antibodies and the antibody response in people who have received first dose AstraZeneca, second dose mRNA. And the data that we have suggests that the response looks better in people who have that mixed dose. So, the combination of, the mixed AstraZeneca first, mRNA second doesn't look worse. We have abundant mRNA vaccines right now, and we know that there is that risk of VIT with the AstraZeneca vaccine that we don't have with mRNA. So based on that constellation of sort of supply issues as well as emerging data, that's really, I think, pushed us towards recommending that people do get a second dose of mRNA vaccine if it's possible. But again, I think it's really important to remember as we have this discussion and as we've had these discussions, over the past several months, is that, the advice that was given 2 months ago or a month ago wasn't wrong advice at the time. It's just that our situation is changing. We're sort of providing vaccine guidance during the course of a pandemic. And so we have emerging data, we have different changes in terms of supply. We have, you know, 2 months ago, we were in the midst of a very bad third wave, and we really just wanted everybody to get vaccinated as quickly as possible. So as much as this can feel frustrating and overwhelming to have this changing data and people may be feeling like they didn't get the best vaccine, the reality is that all of these vaccines are highly effective for preventing severe outcomes. And we're making these changes based on the changing realities on the ground.
I was going to ask you that because there are people who've had 2 doses of AstraZeneca, and I'm thinking that yes, we worked with the science that we had at the time, but if that's the vaccine that you had, maybe you are feeling a little bit more stressed. Maybe you don't feel as safe as other people who've had the mRNA vaccines. What would you say to those people?
I would say that, based on the data that we have right now, 2 doses of AstraZeneca are highly effective for preventing hospitalizations and mortality. And the reality is that's what really matters the most. They seem to be less effective for preventing symptomatic infection, but if you are infected but don't go on to develop those severe outcomes, we sort of defanged the virus, which is not to say that, having a symptomatic infection is nothing. It matters. And, that's important. But, you are very well protected against the worst outcomes of infection. And the other piece to this is, as we have more data, as we sort of study the longer term protection that people have from these vaccines, we may have data suggesting that people who receive 2 doses of AstraZeneca, or even people who receive 2 doses of mRNA vaccine, do need a booster. And that will be provided, and that guidance will be provided over time. But right now, people are protected, and they should feel good about having 2 doses in their arms.
While the WHO has approved the AstraZeneca vaccine, the FDA in the United States hasn't. And I know you've heard this story this past week. Producers of an upcoming Broadway show said that if you have received the AstraZeneca vaccine, you're not welcomed. Only if you've received an FDA-approved vaccine like Pfizer, Moderna, or the J&J. Dr. Chagla, is this something that we should have foreseen? And again, what do you say to people who received the AstraZeneca vaccine?
Yeah, I mean, if you can tell Generation X, that their choice to take AstraZeneca was any worse, this didn't help in that sense.
It's Springsteen.
The reality is, I know, exactly. It's just on one thing on top of another. Again, it's interesting about this U.S. situation because the only reason AstraZeneca wasn't approved wasn't necessarily because of an efficacy issue. It was simply because at the time they had approved Moderna, Pfizer, and the Janssen vaccine, and the signal towards blood clotting with the AstraZeneca vaccine, and eventually the Janssen vaccine showed up. And so there was no market for it to really come onto the U.S. market, and it never really was approved. It does start the broader discussion, though, right? I think we are, as much as we think that vaccine passports aren't coming, there is going to be a need for vaccine, assurance as part of entry, at least into borders, but even more than that. Unfortunately, some of these discussions may be arbitrary. One country may use a certain vaccine, but not use another based on what they've approved and what they have access to. Remember, globally, these vaccines have had inequitable access. Some countries, very minimal access through COVAX to have a set of vaccines. And so I think we do have to give pause. We do have to go through a standardization process, and the World Health Organization is starting to standardize vaccines, both from the typical drug manufacturers from China, from Russia, from India. I think that does start the broader discussion of what we think is fully immunized. And we can't really discriminate people for not getting a preferred vaccine, but still doing their part to get the first vaccine available. We do have to make sure there's some equity out there, and that's really up to our federal and provincial leaders to regulate it.
And Maria, Health Minister Christine Elliott said this past week that guidelines were coming of what people can and can't do now that they've been vaccinated. Well, I've also heard from viewers, seniors who've said that they weren't able to get a vaccine because they're immunocompromised, but they don't know what to do. How important is that discussion, communicating what we can and cannot do if we are vaccinated or not vaccinated?
I think it's incredibly important, and if only because it's something that people really want to know. But it's also really helpful to say, hey, here, if you're fully vaccinated, here are the things that you can do safely. You can, for example, theoretically hang out in an indoor environment with another fully vaccinated person. That's a low risk interaction. So hopefully that will be a component of these guidelines. I do think it's really helpful for people to have that written down. I don't think it's fair for us to say, well, just use your best judgment. Not all of us are infectious disease epidemiologists, and some of us just really need to, we want to see the guidance. That being said, what I'm concerned about is using full vaccination as an incentive for freedom at this point, because we've seen so many challenges again with vaccine equity, on a local level, but also on a global level. That if we say, hey, if you're fully vaccinated, here's all the things you can do, that's going to feel really terrible to people who haven't had the access to that second dose yet.
And of course, you mentioned children before. Ashley, wanted to follow up with that because, we've been talking about vaccinations protecting us against the Delta variant. But that doesn't mean that you can't still get COVID even if you're vaccinated. But children under 12 can't be vaccinated yet. How worried should we be about getting this under control if none of the vaccines are approved for children under the age of 12?
Yeah, no, it's a really important question. And it's something that I think becomes more and more important as we have more of the population vaccinated and as we start having these conversations about opening up and having freedoms. Because, it's not just children, it's also people who, haven't been vaccinated for various other reasons. And, when we start talking about what people can do when they're fully vaccinated, it starts shifting responsibility towards the individual. And, there's this sense, well, you've been vaccinated, you get this reward, which on the one hand is appropriate because we do want people to get vaccinated and we do want them to be able to understand that vaccine does provide them with those freedoms. But we also have to understand that we're talking about a communicable disease. And we do have pockets of our population who are vulnerable and who, can't shift that responsibility onto them. And kids, I think is a perfect example of that, where, come the next couple months, as we start opening up and as I think, we start talking about the return to school in the fall, we have a highly vulnerable group of people who are going to be spending time indoors in classrooms without the benefits amongst the younger kids of being vaccinated. And so if we, don't get COVID numbers down to really low levels, via vaccination and via, I think this cautious reopening, which is really important, then we have to be aware of the fact that there's the potential come the fall that we have really large outbreaks happening in kids and in other unvaccinated population groups. And, I think, the conversation around schools and kids is highly polarized. But the reality is that this is a novel infectious disease and there's no immunity in our population, which is why we had, a pandemic. But, if we allow this to spread sort of without public health measures in place in kids, we can expect to see large numbers of people getting infected. And, some of those kids are going to have bad outcomes. So I think we need to be aware of the fact that just because we reach these vaccination milestones, this pandemic hasn't gone away and it's not going to go away for a while. And so we really need to be focused not only on those vaccination targets, but also on, what's happening with transmission in our communities and in these pockets of vulnerable people.
Maria, I saw you nodding your head.
Oh yeah, absolutely. I think the big thing that I agree with you, Ashleigh, on is that this discussion has really been highly polarized, which I think is a little unfortunate because, of course, as you mentioned, the most important thing is we need to make sure that all of us are protected. And if we have this large group of people in our population, children, who can't be protected by a vaccine, we can very much expect that that pathogen will move through that group that's not protected. And we know that children can get severe disease. And we also know that they are what's called high degree nodes in contact networks. They tend to have a lot of people that they interact with. And that also means a lot for us in terms of infectious disease protection. So yeah, I agree with everything that you said.
It's been interesting to see this discussion with around schools and patios. I think when the government decided to open patios on social media, it was kind of like, ah, and we're having these kind of conversations I don't think we ever imagined we would have like 2 years ago, trying to decide who do you see in your social circle? Do you have 1 dose, 2 dose, no dose? How do you ask those questions? And Dr. Chagla, we look at the U.S. And the CDC recommended that they don't need to wear a mask anymore. Is not wearing a mask possible in our near future here?
Yeah, I mean, it's interesting. I think, working in a healthcare environment, I don't know if we're going to get rid of masks very quickly, for what they've done for preventing nosocomial transmission of not just COVID-19, but other respiratory pathogens. As much as we, don't like them in certain contexts, they may have a universal good there. And it may be one of the settings where it gets enshrined. Is there a pathway out of masks? Yeah, I think so at some point in time. But, as was mentioned, children in schools, particularly next year, they're a vulnerable population. It could very well still spread through, and masking may need to be a part of that, really, as a mitigation technique, as well as things like ventilation and adequate class sizes to support children being in schools and not leading to outbreaks and disruptive learning. From a societal standpoint, I think we do need to maintain masks, particularly because there are such risk gradients amongst people, at least until we have a significant threshold of adults and the ones that could be overrepresented in healthcare really immunized, such that at least we don't see the masks coming off as a large transmission event. And I think we look at the United States. Many of us in envy, I think, watching the basketball and hockey playoffs now, seeing full stadiums and saying, well, why can't we get to that? We're barely even allowed to be indoors with people. Again, that is also the cost of a large vaccine campaign, but also a large number of people that derived natural immunity the hard way while getting infected. The combination of the two puts them slightly ahead of us in terms of vaccine efficacy and population immunity. And so, we are still a ways away back from then, although heading in that direction carefully without necessarily having the secondary damage from how much transmission they had during their first 3 waves.
And Ashleigh, last week, and we saw a lot of patios brimming because that is something that we can now do. Is there a risk that people will, maybe forget about the precautions that we had, and this is happening too soon?
I mean, there's always a risk, right? I don't, it's not something that really worries me, to be perfectly honest. I think, the fact that we're doing this slowly, we're doing things primarily outdoors, the indoor shopping stuff is, to me, relatively low risk. People are wearing masks still. I think, in general, the guidance around taking things outdoors and really, recognizing that outdoors is lower risk has gotten through. And of course, there are people who are going to, push things a little bit farther, and there are going to be people who, start inviting people over to their homes and whatnot. But I think sort of on the sort of population level, I don't really worry about that. I think that the plan that we have right now is good. I think that it's appropriately cautious. And I honestly think that at this point, everybody wants this to be over. And we don't want to be talking about another period of lockdowns or restrictions. And so I think in general, people are slowly and cautiously, loosening their behaviors and sort of recognizing the fact that risk is going down. But I'm not particularly worried that individual behaviors are going to take us off track. I think if anything, it's going to be the sort of larger plan, and if we rush things too quickly.
And Maria, many businesses are prepping their employees for a return to work. Is there anything they need to consider before calling people back into the office?
I think there's a lot of things they need to consider. And, both my co-panelists kind of made reference to this. The idea that this is kind of an individual level responsibility, I think, is perhaps not really an accurate description of how we want to control infectious diseases and pandemics. We have to think about the systemic structural factors that help people stay safe and also help them follow the guidelines that we can give them. And so this, in terms of workplaces, this includes things like, being flexible for people who still want to work from home or still would prefer to work from home. It includes things like improved ventilation, flexibility for desk placement. But also then I think we've seen really consistently throughout this pandemic, a sort of a co-pandemic of mental health challenges. And I think that many people wind up accessing mental health care through their work, through EAP or through other resources. I think it's really important for companies to continue providing those resources and saying, hey, we're not going back exactly to how things were in 2019. We are all different people. And we've all gone through something together. And we need to sort of acknowledge that and continue acknowledging that as we sort of move back from this pandemic and recover.
And Dr. Chagla, I'm going to give you the last 30 seconds. Schools coming up in September. What should schools and the government be doing to prepare for a safe return to school in September?
I mean, number one, preparing now, right? And I think we've been caught flat-footed being, too delayed in this. I mean, again, class sizes, improved ventilation, really consideration of a mask policy at that point until community numbers are stable, and trying to minimize the number of days of kids away from school and having a test strategy developed for kids. Those are going to be the pieces of an unvaccinated population that's going to keep them safe until, again, the vaccines start reaching them long term when we get the clinical trial data.
Again, thank you so much. You three are excellent communicators, and whenever you're on the show, we get lots of emails from people saying how much better they feel about knowing this information. Thank you so much for your insights. We appreciate it.
Thanks so much.
Thank you.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.